Why was this child with simple dysentery suddenly not passing urine and then started having seizures? And more importantly, how did we catch it just hours before his kidneys failed completely? It was early morning in the emergency department when a 3-year-old boy was carried in by his mother. He looked drowsy, pale, and irritable. His mother said, "Doctor, he's had loose motions with blood for 2 days. The clinic said dysentery, gave ORS, but he's not improving." She was tired, not panicked yet. The referral note read, "Acute gastroenteritis with bloody stool. Continue oral rehydration." But something didn't fit. Now pause here. This is where most clinicians can get misled. Because bloody diarrhea in a toddler, dysentery, give fluids, maybe an antibiotic. Admit. But I had seen this trap before. The child wasn't dehydrated. His eyes were slightly puffy now. And his mother added, almost as an afterthought, "Doctor, he hasn't passed urine since last night." That changed everything. I pulled down his lower eyelid. Pale, paper white. I checked his shins. Tiny red dots. Petechiae, too small to blame on scratching. And then the breathing. Not fast, not deep. Sighing, irregular, like the body trying to exhale rising acid, because the kidneys had stopped. This was no longer dysentery. This was Hemolytic Uremic Syndrome, until proven otherwise. Now think carefully. This is not just severe shigellosis, because shigellosis doesn't typically crash platelets. This is not anaphylactoid purpura, because there's no typical rash, no joint swelling. And this is not simple dehydration, because dehydration alone cannot explain total oliguria and sighing respiration. This is HUS, and the clock is ticking on his kidneys. And here is the dangerous mistake many still make. They start antibiotics, thinking it's dysentery. But in STEC-related HUS, antibiotics can trigger a massive release of Shiga toxin from dying bacteria and accelerate kidney destruction. The IDSA and AAP guidelines are clear. Avoid antibiotics and antimotility agents until you have excluded STEC. So we did it step by step. First, strict fluid assessment. If he's becoming oliguric, that's your red line. Next, urgent labs. CBC, smear, creatinine, LDH, looking for microangiopathic hemolysis and falling kidney function. Then, nephrology on standby. Early dialysis if anuria persists. Within hours, his smear showed fragmented red cells. Platelets dropped, creatinine climbed. We shifted him to ICU. Supportive care was our weapon. Strict fluid balance, electrolyte correction, patience. By day 5, urine started trickling back. He survived without long-term renal damage, only because we didn't treat the obvious and looked for the hidden.